Cardiovascular surgery. Cardiopulmonary bypass is one of your cardiac surgical procedures. It's also known as a CABG. We call it extracorporeal circulation, where we mechanically circulate and oxygenate the blood outside of the body while the beating heart is stopped. Disadvantages of this procedure includes a long operative period, the need to administer anticoagulants, hypotension, an increased risk of stroke, and dysrhythmias. It's indicated if the client has multiple coronary artery occlusions. This is also called a coronary artery bypass. So, bypass graft, and that's where the CABG comes from. Basically, what we're doing is we are taking a piece of vein from somewhere else in the body and we are attaching it to where we have good blood flow. We're bypassing the clot or the obstruction and going down past that obstruction and now attaching it to the blood vessel lower. So it's a bypass. Arthriomas are calcified and non-compressible, is another indication. Or we have an anatomic location of the occlusion that interferes with the safe insertion of a coronary artery catheter. In other words, we're basically not able to open up that occlusion with our usual methods, the arterial catheter with a stent, etc. Procedure, once again, as I was explaining, we're going to bypass or detour around the occluded portion of one or more coronary arteries with a relocated blood vessel. The graft vessel is also often taken from the saphenous vein, and the saphenous vein is located in the lower leg. It can also be taken from the internal mammary vein, the internal thoracic arteries, the basilic vein, or the cephalic vein in the arm, or the radial artery. We can also take one of the arteries from the stomach. There's several different types of surgical techniques to complete this procedure, and I talked to you about the CABG, but we also have the off-pump coronary artery bypass. We have the minimally invasive direct coronary artery bypass and the port access coronary artery bypass. Each one of these procedures have their advantages and disadvantages. A client is recovering from a conventional coronary artery bypass graft or CABG procedure. The nurse can expect the following: assess a 12-inch mid-chest incision, anticipate a 3 to 4 day hospitalization, a shorter recovery period due to no use of the cardiopulmonary bypass machine, or minimum of 1 to 2 grafted arteries. This is assess a 12-inch mid-chest incision. Another type of coronary surgery that we might do would be valve repairs or replacements. There's a variety of ways of completing this repair. We can do the commissurotomy, where we have openings of adhesions in the valve cusps. It does require a thoracotomy, where we're opening up the chest wall. A balloon valvuloplasty, where a balloon catheter helps stretch the stenosed valve. The cardiopulmonary bypass. A valvuloplasty, where we go in and repair the valve. Or an annuloplasty, where we repair fibrous rings that encircle the valve. Again, we can replace the valves. We can do it with a mechanical valve, and there's pictures in your slide that show that, or a bioprosthetic valve. And one of the creatures that we can obtain some of these biovalves from would include pigs, because human and pigs really have a very similar tissue makeup. Advantages of valve replacements: we have less surgical trauma, decreased blood loss, faster mobility, less mechanical ventilation, and improved cosmetic appearance. We can also do surgery to repair the ventricular aneurysm or remove heart tumors. A ventricular aneurysm can be caused by an infarcted area of the myocardium that balloons outward, and it forms thrombi. So we start seeing the clots. Can be caused by a myocardial infarction, and it does require emergency procedures to suture those weakened areas so they don't rupture. With the removal of heart tumors, these can be benign or malignant tumors. They are pretty rare. Benign tumors can extend from the pedicle. They're usually uncomplicated. With a malignant tumor, these usually have poor prognosis. We can repair heart trauma, let's say from some type of a laceration due to a blunt chest trauma, or maybe a penetrating wound such as a stab wound or a gunshot wound. We can have that non-penetrating injury of the chest that results in cardiac tamponade, and this once again is where the pericardial sac begins to fill with blood or fluid, and it compresses the heart so much that the heart loses its ability to pump. Can be caused by the crushing chest injuries, causing bruising and bleeding. It requires bed rest, a pericardiocentesis, where we insert a needle into that pericardium to help remove some of that fluid, and an open thoracotomy to repair any damage. With a penetrating wound, once again, stab wounds or gunshot wounds, we're going to repair the large tears with surgery. It can cause immediate shock from hemorrhage because we deal with massive amounts of blood going through the heart. A heart transplant is another type of surgery. Causes or needs for a heart transplant would include cardiomyopathy or end-stage coronary artery disease, end-stage heart failure, congenital cardiac defects. People that require a transplant go on the National Organ Transplant List. With a heart transplant, we're talking about some potential issues, one of which is rejection. This is foreign tissue that is going into the client's body. We may see a hyperacute, acute, or chronic rejection. With rejection, the client may experience fever, flu-like symptoms, shortness of breath, chest pain, weight gain, fatigue, elevated blood pressure. They're going to start showing symptoms of heart failure. So they're going to begin to develop that edema, the shortness of air, etc. These clients with transplants will require immunosuppressive drugs, such as cyclosporine or azathioprine. They're at risk for infection caused by bacteria, viruses, or fungal infections that can be exacerbated or supported by the immunosuppressive medications. That's knocking out the body's natural ability to fight these infections off. Symptoms of infection may be very similar to rejection symptoms. Infection can be life-threatening. We do treat it with antibiotics, antivirals, or antifungals. There's a high cost related to heart transplants. The client is going to go through a pre-heart transplant evaluation. They're going to have the surgery. They're going to be on lifelong medications. They're going to require post-surgery care and follow-up tests. And this can add up to millions of dollars. And cardiovascular disease, or CAD, is a common problem among heart transplant recipients. These clients are not going to typically experience angina because the heart's nerve supply is no longer intact. When they remove that heart, they cut those nerve endings, so they don't feel chest pain as they would have before. The rate of survival is 85% to 90% for the first year after surgery. 10-year survival rate is 56%. And we also have to consider that there are a scarcity of donor organs. 20% of 3,000 people awaiting a heart transplant will die before the donor becomes available. Clients awaiting heart transplantation are assigned a status code that corresponds to their medical urgency. The nurse understands that if a client is determined a status 1B, the client must have the following qualifications. The client is considered temporarily unsuitable to receive a thoracic organ transplant. The client requires mechanical circulatory support. The client requires continuous medical ventilation, or the client has a left or a right implanted ventricular assist device. This is D. The client has a left or right implanted ventricular assist device. We can also do central or peripheral vascular surgical procedures. This would include vascular grafts, where we bypass or replace diseased sections of major systemic blood vessels, such as the aorta, or the femoral artery, or the popliteal artery. One condition that we may see this in is in severe peripheral arterial disease, where we no longer have sufficient blood flow to the lower extremities. So we bypass those areas of occlusion. Types of vascular grafts include synthetic fiber or human tissue. We can do an embolectomy or a thrombectomy, where we remove a thrombus or embolus that may be occluding a major vessel. We can do a replacement graft or an endarterectomy. An endarterectomy is often done on the carotid arteries, where we begin to have occlusions of those carotid arteries, and we're no longer getting the proper perfusion to the brain. This procedure is going to resect and remove lining of an artery, or remove atherosclerotic plaques from the aorta, the carotid, the femoral, or popliteal arteries. So how do we take care of these clients that have undergone cardiovascular surgery? They do require that hemodynamic monitoring, where we're assessing the volume and the pressure of the blood in the heart and the vascular system, usually through a surgically inserted catheter. We can do this through blood pressure monitoring, where a catheter placement is done in a peripheral artery, such as the radial, the brachial, or the femoral artery. We can do the central venous pressure. Usually this is obtaining the right atrial pressure. Normal is 2 to 7, or we can do this through the jugular or subclavian vein. We're monitoring the perfusion. We're monitoring how hydrated the client is staying, etc., with the CVP. Or we could do the pulmonary artery pressure monitoring, where we assess the left ventricular function. How well is it pumping the blood out to the body? We can do pulmonary capillary wedge pressures, where we're determining the left ventricular end diastolic pressure and cardiac index. A client recovering from cardiovascular surgery is at risk for decreased cardiac output related to impaired ventricular contraction. To maintain an adequate cardiac output, nursing interventions include elevating the head of the bed as much as possible, administering prescribed inotropic and antidysrhythmic medications, assessing sternal or lung incisions for redness, or encouraging leg exercises every, I'm not sure how long, while awake. It's administering the prescribed inotropic or antidysrhythmic medications. And your post-test.